morning to everyone. Thank you so much for joining us today for our webinar. I would like to thank Marianne, Rachel, and Taylor for presenting today and joining us. Marianne and Rachel are from Harvard Center of Policy and Law and Innovation. It's a long title. And Taylor is here locally from Planned Parenthood. And they're going to be talking about the recent Supreme Court amicus brief that was submitted about moral exemptions and reproductive care and that impact that it has on our community and people living in North Carolina and in our country. So this is something that's not COVID-19 related. We can have a little break today, and I think that's welcomed, especially with all the craziness going on. And I'm really excited to hear from Marianne and Rachel about the case and to kind of do a deep dive there. And I'm excited to hear from Taylor about how, you know, things on the federal level are being reflected down here locally and how that's affecting policy for us here. So I'm going to go ahead and get started. Feel free to add questions in the chat, and I'm assuming there will be breaks throughout the presentation for Q&A as well. So definitely take advantage of the expertise that's here. And if you have a question, if you don't understand something, especially if it's dense or whatever, feel free to ask. And I'm looking forward to have a great conversation. So go ahead. I'll go ahead and pass it off to Marianne and Rachel.
Thank you so much, Christina. Let me set up the screen share. Fantastic. So thank you, everyone. Thank you to Lee and Christina for inviting us to speak. My name is Marianne, and my colleague Rachel and I are very excited to join everyone this morning to talk about the Supreme Court fight to protect the contraceptive coverage mandate. As Christina mentioned, Rachel and I are from the Center for Health Law and Policy Innovation of Harvard Law School, and we too agree that that is a super long name, and so feel free to call us CHLP for short. Our work focuses on promoting access to healthcare for vulnerable and underserved communities. We work across the country, but have a very long history of working with HIV advocates, particularly in the South, to demand affordable, high-quality access to treatment and services. Rachel and I are particularly excited to talk about today's topic because we both have a background in public health. And between us, we have worked in reproductive justice organizations, direct medical services, and in public health agencies. And this court case threatens the very core principles that many of us on this webinar bring to our work daily. And it threatens a lot of progress that this country has made over the past decade. Before we jump to the court case, though, I recognize that there are many on the call who know this issue like the back of their hand. But I'm also guessing that some folks are new to the issue. So I want to first take a step back and set up the background for the case and talk about what's at stake and why this is such an important issue to be aware of. So I'm going to open the gallery view, and just by a show of physical hands, nothing too fancy, how many people here know of someone, and it can be yourself, who has delayed medical care because of cost? I'm betting that, that many of you have also seen someone delay preventive care like birth control, PrEP, STI testing, and other screenings because of cost as well. And this was one of the exact reasons why we needed the Affordable Care Act, or the ACA, in the first place. Too many people were either uninsured or underinsured and did not have meaningful access to basic preventive health care. Formerly, I was an EMT, and a number of the calls that I answered prior to the ACA had to do with people who felt like they had to ration preventive healthcare, like being able to monitor their diabetes, or not addressing a symptom early on and waiting until it progressed to the point where they needed emergency care. While we still have too many people without healthcare coverage, thanks to the ACA, we have 18.6 million fewer uninsured people. And nowadays, when people do have health insurance, they can expect a core group of benefits to be covered, including key preventive healthcare that's fully covered at no additional cost.
And so to give a quick overview of what we'll be talking about today, we're sort of going to do a bit of a history lesson that will take us to the Supreme Court case. And so we have first how the ACA expands access to preventive care and the types of care that's included in that. We'll also talk about challenges to contraceptive coverage specifically, because that's been really controversial since the passage of the Affordable Care Act. We'll talk about the 2018 rule changes that are the focus of the current Supreme Court case, Trump v. PA, which really created broad exemptions from coverage on the basis of religious and also moral objection. The arguments against those rules, we'll talk about the arguments against those rules that we made as CHLPE together with the North Carolina AIDS Action Network and a series of other organizations in an AMICUS brief, or a friend of the court brief, which is really a cool opportunity for parties that aren't actually litigating a case to bring certain other important pieces of information to the court's attention. And then we'll also talk a little bit about getting involved in advocacy around the Supreme Court's review of the case next month.
So prior to the Affordable Care Act, healthcare plans were all over the place. Depending on who you worked for, where you lived, how much you could pay, what pre-existing conditions you had, you may or may not have had access to basic preventive services. And so the ACA helped standardize this with the preventive services mandate. It requires new health insurance plans to fully cover 4 sets of preventive care at no additional cost to consumers. So services that receive an A or B rating from the United States Preventive Services Task Force, certain recommended immunizations, specific care and screenings for infants, children, and adolescents, and preventive care and screenings for women. These services are all evaluated and recommended by independent medical providers, and in some cases are required to be adopted by a government agency. And these 4 sets of services actually cover a wide range of preventive care, many of which are important for people at risk for or living with HIV, hepatitis C, and other chronic conditions. For example, the United States Preventive Services Task Force gave PrEP an A rating last year. This means that as we hit new plan years in the fall for students, or in 2021 for many others, people will begin seeing PrEP covered by their health insurer with no copay. Eliminating this cost barrier is significant to helping end the HIV epidemic in the United States, helping address barriers like what Lee's friend faced when he was unsure whether he could go back on PrEP, and also to help address some of the disparities that have occurred in PrEP use and PrEP uptake. Another timely example involves the COVID-19 pandemic. In the CARES Act, which passed last month, insurers are now required to fully cover any service or vaccine that is intended to prevent or mitigate COVID-19 within 15 business days of that service or vaccine being recommended either under either of the first 2 categories in the mandate. So either by being rated an A or B by the United States Preventive Services Task Force, or being recommended as a vaccine by the advisory committee. And then finally, we get to the last set of recommendations that were included to address the coverage disparities that are often seen in women's health. that are not otherwise addressed in any of the other 3 categories of the mandate. So to help the government figure out which preventive care and screenings were critical in this regard, a panel of medical providers convened to go over research and to review various preventive healthcare services that had clinical benefits for women. And they recommended 8 specific services, all of which HRSA has adopted. So the first being annual well woman visit, gestational diabetes screening, HPV testing, STI counseling, HIV counseling and screening, contraceptive methods and counseling, breastfeeding support, supplies and counseling, and interpersonal and domestic violence screening and counseling. This was a major win for women, especially in areas like contraception or breastfeeding support, where cost was a huge driver behind disparities and a lack of uptake, and also in areas where screening was lacking. So the big one that we'll focus on today is the contraceptive methods and counseling. This recommendation was a big win for the very reason that Christina is bringing up in the chat, in that this recommendation meant that women don't have to limit their birth control options based on how much money they can spend in a single visit, or whether they can even afford to pay for an initial consultation, an IUD, a placement and removal, or any of the other costs that usually came with birth control. Women only needed to work out with their doctor which form of contraception was the most appropriate for them, and they could get it covered in full by their insurer. Unfortunately, the story doesn't end here, and it's not a simple one. Before insurers were even required to cover contraception in full, religious organizations started fighting back. Many did not want to cover some or all forms of birth control for their female employees. Reasons ranged from viewing some forms of birth control as causing abortions to a general opposition to preventing pregnancy in general.
But let's be really clear here. From the outset, religious employers, so houses of worship, for example, have been exempt from the contraceptive mandate. They have not been required to cover contraceptives for employees, and employees, accordingly, do not have guaranteed coverage. There are also accommodations in place for religious nonprofits. And importantly, that's different from an exemption because there are alternative processes in place that ensure that employees who want coverage, who want to be able to access birth control, are still guaranteed that no cost, no out-of-pocket cost coverage. And over time, we've also been expanding those accommodations so that other for-profit organizations have been able to use the same accommodation process, but it's been more limited. It sounds pretty reasonable, right? Well, some organizations claim that the accommodation process, which involves filing a form with insurers or the federal government to notify of the objection, is still a substantial burden on the exercise of their religious beliefs. And in response, in 2018, the Trump administration issued those rule changes, which again included sweeping exemptions for any organization with a religious or even a moral objective. And the rules make the accommodation process merely voluntary. So an employer exercising an objection controls whether or not, at the end of the day, employees have coverage. And given the history leading us up to this point, it's hard to believe that many organizations opting for that objection and for that exemption are going to opt in to a voluntary accommodation process. Recognizing the serious impact that the rule would have on their residents, Pennsylvania, joined by New Jersey, filed a lawsuit, and a federal court then temporarily stopped the rules from going into effect while the case is playing out. The Trump administration then appealed to the Supreme Court to say the rules should take effect. We should start playing by these rules while the case is still playing out. There's no reason for them to be on hold. And that's where we are today with the Supreme Court case. And so what is the legal argument that the rules cannot stand? There are a few different angles, but we'll really focus today on the issues that we talked about in our amicus brief. And at its core, this was about the idea that when the Supreme Court considers religious accommodations, they have to consider third-party harm. And so the impact on others. The third parties here include employees and their dependents whose employers exercise an objection. Third parties include students enrolled in a school health plan that exercises the objection. The Supreme Court has to take into account the effect on all of those individuals. We talked about the harm that the rule would cause for people living with chronic illness for whom birth control is a critical component of healthcare. We also talked about the ways in which the rule will harm people at risk for and living with chronic illness who benefit from other essential life-saving preventive care beyond contraceptives. And we'll talk a little bit more about each of these arguments.
So we thought it was important to first emphasize why birth control is critical to healthcare. Birth control allows people better control over their reproductive health, yes, but that's not all that it does. For one, it gives people flexibility and control to improve their overall health and avoid pregnancy-related detrimental health effects. For example, pregnancy can lead to disease progression in some chronic conditions such as lupus or chronic kidney disease by exacerbating existing symptoms. So meaningful access to contraception can give people the autonomy and the agency to direct both their reproductive futures, but also manage their chronic illness. We also wanted to highlight that sometimes the medications that we need to take require use of a specific form of birth control due to the mechanism of the drug, or requires you to use multiple forms of birth control due to the effect that drug has on fetal development. And people living with chronic illness don't need access to just one type of birth control. They need coverage for the full range of FDA-approved drugs so that, depending on their specific condition, can access the contraception that is most appropriate for them without a financial barrier.
In addition to talking about the importance of birth control, we made what's commonly called a slippery slope argument. So we talked about the ways in which, if extended, or ways in which, in addition, if we were to continue to pursue this kind of argument, there'd be more harms and it would be amplified. There's still so much moral judgment attached to certain sexual activities and to injection drug use. And so we used services like PrEP, the HPV vaccine, and the Hep B vaccine to say that it's not hard to imagine people objecting to coverage for these critical prevention services and wanting the same exemptions from coverage because paying for access somehow means that you're enabling or promoting these activities. We talked a lot about the individual level harm that this would cause. Healthcare services, as we started off with, are expensive. PrEP can cost as much as $13,000 a year if someone is paying fully out of pocket. Facing these costs, a lot of people would be forced to delay care or to forego care. And we'd really be further ingraining all and reinforcing all of the sort of health inequity that right now we are reckoning with in the middle of the COVID pandemic. We also talked a lot about how extension of the rule would undermine the administration's ending the epidemic campaign, and other public health initiatives. It's kind of cool because there's this really old case from 1905, Jacobson v. Massachusetts, and that's Jacobson over there in the image. And in 1902, during a smallpox epidemic that was centered in Massachusetts, Jacobson, a minister, refused to comply with the terms of a town vaccination order. And he challenged the order as being unconstitutional. Went all the way up to the Supreme Court, and the Supreme Court recognized that there are real public health limits to individual liberty and to religious liberty, and that it is valid for states to exercise that police power. And I know we said we were taking a break from COVID today, but you really are seeing this case come up and play out and be cited in a lot of the conversations around sort of stay-at-home orders and whether or not it applies to places of worship. So Jacobson continues to be a really relevant case in kind of public health law, and we definitely pulled it on into our case to say that there has to be limits on accommodation, and this needs to be one of them here because initiatives like ending the epidemic are so critical, and because coverage for services like PrEP is so fundamental to any progress in that space.
So this is our last slide that we have prepared today. Because of COVID-19, the Supreme Court is actually making the audio of oral arguments available to news outlets. They're having all of the oral arguments done over teleconference, talk about a new day and age. And this particular case, which is called Trump v. PA, or Little Sisters v. PA, because there are two cases that actually got consolidated together. This particular case will be live on C-SPAN on May 6th, which is a Wednesday at 10 a.m. Eastern. Under normal circumstances, oral arguments would be certain to draw out hundreds of protesters outside of the Supreme Court to help bring visibility to the case and to also to show the media and viewers at home who stands to be affected by the court's opinion. In lieu of a in-person presence, though, many organizations will be joining in social media campaigns to bring a virtual presence to this argument. And so we have two examples of the one on the left was created by the National Women's Law Center, and then the one on the right was created by Chilpi, quoting one of the advocates that joined us on this amicus brief as well. So if you are interested in being involved in kind of raising the public profile of this case, I strongly encourage you to just hang out on Twitter and Facebook and join in some of the conversations that will surely be happening on May 6th. I'll pause here if folks have any questions or comments, or if you want to share an experience that you've had with preventive care, or maybe you're one of the experts in the room and want to share like what it was like making sure that insurance companies across the state were covering the preventive services they needed to without copays. So I'll just pause here and see if any folks want to share or have any questions.
I have a quick question about the oral arguments happening on May 6th. So obviously, like, people can't congregate there like they normally could, but how are the justices and the lawyers that are involved going to be operating? Is that going to be different? Is there going to be like way more space in the court, or how is that going to work? I mean, I don't know how cases have been going this time, like all during this time. I thought that they were shut down.
It's even more like surreal than that. So at 9:15 in the morning, the lawyers on each side of the case call in, or they get called by the court to run through some of the rules for the day, and then they hang on to that conference line for a good half hour until they collect all of the other justices that will be calling in from each of their respective homes that they're currently quarantining in, and they all join a conference line. And in typical Supreme Court cases, each lawyer gets a set amount of time to present their argument. But in reality, they only get maybe 2 or 3 minutes of uninterrupted time before the justices start peppering questions and interrupting them. And so they're going to have a modified version of that where the lawyers will be able to talk for a couple minutes uninterrupted, and then they'll go justice by justice in order of seniority, allow each of the justices to interrupt and question. And then before it moves on to the next justice, And then at the very end, any justice that wants to speak up can interrupt them. But it's all teleconference. Everything's going to be done. It gives a whole new meaning to like conference call bingo. Hopefully everyone gets their lines muted, but it's going to be a very interesting way to not only operate the courts under like the pandemic, but also I think it makes these proceedings a little bit more transparent, because otherwise the only way that you could join the arguments in real time was to be there in physical, like have a physical presence in the courtroom.
I, for one, hope that people do not mute their lines and we get to hear some really interesting conversations, hear what people really feel. That would be hilarious. And I'm very curious to see how this is going to look on C-SPAN. Is it just like a graphic and then just audio, or?
In previous C-SPAN, C-SPAN does pick up the audio recordings of Supreme Court arguments, but usually it takes a week before they actually put it on C-SPAN. And what they'll usually do is they'll take photos of whoever's speaking and just pop it up when they're speaking. I don't know if that's going to run in real time, and whether C-SPAN is going to be able to still help you figure out which justice is speaking and which lawyer is speaking. It's a new world.
I know. But more on policy, I feel like depending on, I know after oral arguments, there is a bit more time before, the case goes on, but I feel like fast forwarding to the future, like what's the worst case scenario and then best case scenario when it comes to the Supreme Court's ruling on this case?
So I think part of what makes this hard is there's been such a sustained assault against reproductive rights in this administration that this case doesn't even exist in a vacuum. And so when we think about the kind of, and Taylor can probably speak more to this than I can, but when we think about like a worst case scenario, part of the issue is that you have the administration saying it doesn't matter if women lose coverage because they can go head to a Title X clinic and get coverage there, which is a kind of a federally funded program for family planning services. But when you peel back that argument, you see there's been an assault on Title X and Title X clinics. And so it all starts to really snowball. And so I think the worst case scenario is really hard to even, for me, to kind of wrap my head around right now. I think the best case scenario is we would see a really strong recognition that the harm to employees, to students, to women, to people living with and at risk for other chronic conditions are recognized by the Supreme Court. And that we say that this matters, and we say that there has to be a limit on religious liberty and sort of individual decisions there.
So true.
I just saw Christina's comment about birth control, and I remember when the HPV vaccine first came out, and we're talking about a major like cancer prevention vaccine, and everyone was so caught up with the idea that you'd be vaccinating teenage girls and that it would be promoting like underage, like premarital sex.
I know. For context, I mean, my parents are very, very religious, very pro-life, very that, you know, those people. But they heard birth control and that like triggered them, and they were just like, "Wait, what? No, but that would mean that you're having sex and you're not doing that." And it's just like, we're not even talking about that. We really weren't even talking about that. So, I think about other kids who are similarly situated, particularly in the South. I know that that's a thing. And I just worry about, you know, their access to things like PrEP, birth control, and how their parents could get in their own way in a way if they're not careful.
It's a very good point, Deshay, in the comment. You know, even with the preventive services mandate, requiring plans to cover a lot of these preventive services without any copay, and also even taking away a lot of the stigma that can be associated with certain preventive services. Sometimes, like, there are a number of people who don't know that these services are covered, or if they are already using birth control, don't understand why that all of a sudden there's no copay, and that kind of background insurance knowledge is not something that's very widespread, and has been a problem when it comes to, you know, gathering support for the Affordable Care Act, because people hear Obamacare and they immediately say, no, I don't want any of that, when they are already benefiting by the mere fact that they now have, they don't have to pay for key vaccines or key screenings, or new mothers having access to pumps and support like that. That's a very good point. I'm going to go ahead and stop share and pass it along to Taylor. Taylor, feel free to take over from here.
Okay, perfect. Yes, thank you. You guys, I feel like you provided a really good overview of the ACA fight. I work with Planned Parenthood South Atlantic. I'm the Black Organizing Program Specialist, and I'm glad that we are discussing this topic today, because the ACA has been an important part of Planned Parenthood's own advocacy work, and I'll be discussing the advocacy timeline and ways that we have fought for these rights across the country, as well as other reproductive healthcare fights that have been impacted as well and have also taken place around the same time as advocacy around this issue. So I will share my screen now and get started. Okay. So just an overview of what I'm going to go over during my time. I will give an advocacy timeline based on some of the really critical moments in this fight, because it has been a decade since the ACA passed in 2010, but this has been a monumental time, not only for Planned Parenthood, but other movement partners that have been working to protect access to care. I'll also go over why this fight matters in North Carolina and some of the other issues that we've been working on here in this state, as well as fights that we have led the charge in terms of specifically the campaign to protect Title X. So that will be uplifted along with some of those other movements that have already been mentioned, as well as just quickly discussing some of the reproductive healthcare services that are offered in North Carolina, and the services that are also impacted by the loss of funding to Title X. And then I'll also be discussing access to PrEP and PEP. So just a basic advocacy timeline. In terms of this movement, there have been some really critical moments In March of 2010, the Affordable Care Act was signed into law, including coverage for preventative care like birth control with no copay. Following that, the Birth Control Matters campaign was launched to remind politicians that birth control is very important and should be available to everyone without copays. I do note that this, while this campaign has really been uplifted and led by reproductive health care leaders, this issue is not limited to people who identify as women, and there have been a lot of really important advocacy work by other allied organizations as well, and that these other periods of advocacy work have really taken place along with other fights that really ramped up around this time. So between the time period of 2010 to 2011, aside from some of this other advocacy work and issues that were taking place with the administration at this time, the fight to defund Planned Parenthood really began during this time period. So we've seen a real growth in the politicization of reproductive health care over the past decade. And while this is basically, it's been our reality at Planned Parenthood that our health centers have been closing as a response to that, and that in a lot of cases, while abortion access is the main reason that Planned Parenthood is under attack, that is not the majority of the services that we offer. So some of these restrictions to care have really hindered the ability for people to access preventative measures that impact your reproductive autonomy over your own body, your bodily autonomy, and it's connected to other services that we offer that can be life-saving. And this just goes over some of the other key movements that happened beyond the initial passage of the law. So Planned Parenthood has really increased their advocacy around and education around why birth control is important, following the creation of a white paper, which really connected birth control access to reducing the rate of unintended pregnancies. That's something that really hadn't been politicized. When Title X first was passed, it wasn't a partisan issue. This family planning law was something that was really supported by both the Democrats and Republicans at that time, but over the past few years, it has been more political. So regarding the Birth Control Matters campaign, over 400,000 actions have been taken by Planned Parenthood supporters in support of the birth control individual mandate. These campaigns, although they launched during this time period, they've really ramped up over the past 5 years. We've worked with groups like Bedsider and Power to Decide to support Thanks Birth Control Day. This allows people to share their own stories because we realize in organizing, storytelling is a very powerful tool. We've also worked with people to share their stories, testifying in Congress, testifying at the State House, discussing how birth control helped them, because even with me working in the Charlotte Health Center, I've heard a lot of stories about people who were their ability to be able to access birth control. It wasn't solely for the purpose of sex, which of course, that is a reason that a lot of people do use birth control, but for other instances that really support them in chronic conditions that they have or other health issues that they are experiencing. One thing that I feel is very important to discuss in terms of this measure is that while this mandate is specific to contraceptive coverage, and I will go into some of the things that are covered specifically through this measure, one of the things that I felt was really important to uplift is that this movement, there were a lot of movement partners who joined in that weren't the traditional reproductive health care advocacy organizations that you would think of when you think about birth control access. This is something that I found very helpful. Lambda Legal, they joined in on this fight, and this quote from their policy director at the time, I felt like it really illustrated why this law sets a dangerous precedent for people within the LGBTQ community. And it states that business owners with religious objections to blood transfusion could potentially exempt that life-saving service from their employees' insurance. They could selectively exclude coverage for quote unquote sinful medications that control pain, alleviate depression, manage HIV, or support gender transition. Those who believe that all modern medical treatments interfere with the divine would or could refuse coverage for all but faith-based healing. This is something that we've seen in states like ours, in states like North Carolina, where the politicization of healthcare has really directly impacted our ability to provide care in the state. One example is that in 2014, Planned Parenthood was defunded at the state level. So Planned Parenthood no longer receives state funding for our health centers across the state. And on the other end, our state does provide funding to crisis pregnancy centers, which are faith-based religious organizations that are considered medical in the state's term, but they do not have the same health care requirements that a lot of actual health care centers offer. So partners such as NARAL, North Carolina, have really led advocacy in terms of exposing these fake clinics and highlighting the hypocrisy in the fact that Planned Parenthood is the nation's largest provider of reproductive health care and family planning, as well as sex education. But we're not able to receive that state funding while a religious-based organization is able to do that, and really they have manipulative practices that are harmful to patients who are looking to seek accurate medical evidence-based information. So one thing that I wanted to draw a parallel to was House Bill 2, which passed in November of 2016, and a lot of advocacy organizations in North Carolina, as well as across the country, really stepped up to fight this measure, and it has been repealed, but at the time, this was deemed the most extreme anti-LGBTQ measure in the country. It basically restricted the protections that were created in a Charlotte ordinance by the city council. But while it was deemed the bathroom bill, it really harmed the LGBTQ people from discrimination based on sexual orientation and gender identity, which could potentially establish harmful practices concerning LGBTQ employees and customers. And this is connected with the religious exemption law, because when we're saying that we can allow organizations and employers to determine what coverage they will provide their employers, it opens room for other forms of discrimination, and that's why that bill was so harmful. And in terms of Planned Parenthood, the care that we provide across the state, it really is preventative. We're one of the largest providers of sex education as well, which is covered under the ACA mandate, as well as counseling and other educational measures that are really important in terms of that bodily autonomy that I mentioned, and our ability to protect the ability for our patients to determine what they should do with their bodies, how they should determine the lives that they want to live. And that is something that we feel is a basic human right, and that's why Planned Parenthood has uplifted this fight for so long. And I just included this services breakdown because a lot of people are confused about how Planned Parenthood fits in with this issue. Sometimes or usually a lot of people do, when they think about Planned Parenthood, they only think about abortions. But over 40% of our services are STD testing and treatment. 34% is contraception. So combined, that is over 70% of our services are those preventative measures that are really crucial to family planning, while 3% of our services are abortion, and other services that are also interconnected with this topic as well. And I believe that Marianne and Rachel also really went into this, went into which specific contraceptive methods are covered by the ACA mandate. But I do feel like it's important for people to see, because when our patients are able to make their appointment, they're able to analyze their wide range of options. And that is really important. I know that Christina mentioned in the chat earlier that that the price of birth control varies based on the method that is used. And that's really important because we pride ourselves in being able to allow our patients to discuss their options without judgment. I do think that that is underrated in terms of reproductive health care. A lot of patients don't feel comfortable going to certain providers based on their own experiences, based on their gender identity or their sexual orientation, and Planned Parenthood prides itself in being a provider that supports and empowers our patients to make decisions that are best for them. So whether that is abortion, whether that is finding the right birth control method for them, gender affirming hormone therapy, all of those things are important to us. And that's also something that is connected with the Title X fight, because Planned Parenthood has also been targeted because through Title X, where the federal government was looking to restrict our ability to provide our patients with that the tools to be informed about all of their options across the spectrum. And one other thing that is really important to mention in terms of the ACA mandate is the fact that emergency contraception is also covered, and the fact that in turn medications that induce abortion are not covered as a part of this plan. People do commonly mistake the Plan B emergency contraception pill as an abortion-inducing medication, which it is not. And I think that it is important for us when we're talking about this to see that connection and further discuss that stigma associated with these types of services. So the fight for Title X, it really was a big issue for us. It has been a big issue for us over the past few years. Since the Trump administration really made repealing the ACA one of the crucial parts of their policy goals, we knew that defunding Planned Parenthood would be a priority, and a lot of our patients did too. Since 2017, especially around that time period of the inauguration, Planned Parenthood's appointments for birth control, they really skyrocketed. People were afraid that they would lose coverage through the repeal of the Affordable Care Act, and that resulted in a severe increase in appointments. One other parallel is today, nowadays, where people's ability to access care is being weakened through the high rates of unemployment due to this pandemic. Now we've noticed, we just received a patient story the other day about people still continuing to come to Planned Parenthood for care because hospitals and other places that patients also go to receive birth control and other contraceptive care. One of our patients noted that Novant Health had a 3-month wait to install a LARC because of how swamped medical providers are during this time. So I think that when we're talking about this issue, it is really important to note that this is essential healthcare. There are states such as Texas and other primarily southern states, but other GOP-controlled state legislators across the country are really looking to weaken the ability to access birth control and abortion and other more controversial healthcare services through the fact that this pandemic is happening, and we've seen that politicians are still continuing to politicize this coverage to care. So these are the preventative services that Planned Parenthood offers across the state that have been restricted through Title X, where Planned Parenthood has been targeted because of the fact that we provide abortions, and we are the nation's largest provider of reproductive health care coverage. So we've discussed contraception, but gender-affirming hormone therapy has also been severely weakened through the removal of Title X funds from our organization. And this is really important because Planned Parenthood is the #1 provider of gender-affirming hormone therapy outside of the VA. So this is really something that is weakening the ability of the LGBTQ community to access care as well. And that's something that is important to discuss, because when we're discussing religious exemptions, there's a lot of organizations and employers that would intentionally discriminate against someone who, because of their sexual orientation or their gender identity, especially since that is not a protected class. Some of the other services that are affected are cancer screenings, wellness exams, STI testing and treatment, HIV testing and treatment, as well as access to PrEP and PEP, which is access through our health centers across the state as well. And our ability to provide sex education programming has been severely weakened through loss of Title X funds. So all of this politicization of healthcare, it really does have a direct impact on our on the people that we serve. Right here in North Carolina, in Greensboro and in the Triad, we've had to reduce some of this programming, and it's very important that we discuss it, because in North Carolina, 40% of Title X patients depend on Planned Parenthood. So discussing local access to preventative care, I just wanted to include this right now because I've gotten a lot of questions, and we've been asked a lot about how reproductive health care access looks at our Planned Parenthood health centers. So in response, Planned Parenthood has increased the telemedicine options for contraception, as well as PrEP and PEP, by allowing patients to receive additional months of medication, because during a time like this, reproductive health care isn't the priority for most people to discuss it, but it's really something that is essential for a lot of people in their daily lives. So this is something that we feel like having a timely response to is really critical for people, and it can be life-saving. So I have included some ways that we can continue to promote access to health coverage during this time. One of the things that I also feel is really connected is Medicaid expansion. This has been a big area of local advocacy in North Carolina since North Carolina did not expand Medicaid. 500,000 North Carolinians would receive coverage through Medicaid expansion. And we've been working with a lot of partners, including NCA's Action Network and Healthcare Justice, to uplift this. And we've also been encouraging the participation in the census during this time, as well as continued education around this decision, supporting and uplifting that. And lastly, I just have included some local actions and petitions that have been circulating. Planned Parenthood has a Fight for Birth Control campaign that is online, and you can visit this website and sign a petition, which is being circulated to elected officials at the state and federal level, as well as voter registration. That's something that I noted, and expanding voter protections, because all of these things are connected to voting and our elected officials at the state house, and local petitions around Medicaid expansion, and then continued support for organizations that are uplifting reproductive health care amid this pandemic. And that is all that I have. Sorry if I'm a little bit over time.
No, we have a full minute left.
Oh, okay.
So we're good. We're good. Thank you so much for sharing, Taylor and Marianne and Rachel. This was really, really great. it's really interesting to see how, what's going on the federal level and the politicization of those issues, and seeing that direct impact to us locally is just insane. And especially in North Carolina, especially in Charlotte, I've seen a lot of vicious attacks on people trying to, access abortion, and just a lot of stigma around birth control and all of that. So all of the work that y'all are doing to make this better is really great. And I know as advocates, we're really grateful for the work that you do. And thank you so much for sharing with us information about this case and its impact to us locally. I would like to say thank you to everyone who joined us today for this webinar. This was really awesome. We want to invite you to our next webinar, which is happening next week, next Thursday at 10 a.m. Called Let's Talk About Sex, Intimacy During COVID-19. And we're going to be talking with, different people, whether it be sex specialist, Tanya Bass, locally here in Charlotte. We're going to be talking to, I think, Damon Jacobs, Noah Beecham, but we're going to be talking to different people about sex and intimacy during this time and what that looks like, and having an honest conversation about how dating on the apps and just life outside of sex and in the more intimacy realm, like what that looks like right now in a time of isolation. So it's going to be a very interesting conversation. So we hope that you join us. Lee just posted the link in the chat box if you want to register. And then also on May 6th, we're going to be doing an online fundraiser called Broadway Twisted, which will actually be a Broadway show that we normally do in person over in the Triangle, but because of COVID-19, we're doing it online. So normally different Broadway actors do a show, and they usually do like gender swapped type of show tunes, and it's really just a fun show. And we normally are able to raise money for our organization and other Broadway organizations who work to support organizations who do HIV work like we do. So if you're able to join us, we're going to be streaming the show live on our Facebook Live page. So you can look us up on Facebook, like us, and then you can watch it live on May 6th at 8 p.m. So if you would like to join us and have some plans, go and register for that, kind of, but not really. Just join us live on Facebook Live. And I think that is all I have to say. Thank you so much. We'll wrap up. Bye, everyone.
Thanks, everyone.
Thank you.